Good morning all. Myself Dr. Kalpana Tiwari. I am going to discuss the topic endometrial hyperplasia. So what is endometrial hyperplasia? Endometrial hyperplasia represents a spectrum of morphological and the biological alteration in the endometrial gland and the stroma, ranging from exaggerated physiological response to the hormones, or it can be a precursor of carcinoma in situ also. So what are the risk factors to develop an endometrial hyperplasia? First is the unopposed ovarian stimulation by the exogenous estrogen, or delayed menopause, because in menopause we don't have the progesterone, so there is excess of estrogen that can lead to endometrial hyperplasia. Now another is diabetes, then PCOS, obesity, nulliparity, and the family history of endometrial cancer. All the patients who are having these risk factors are likely to develop endometrial hyperplasia. It can be with atypia or it can be without atypia, both. Now how is the pathophysiology of endometrial hyperplasia? First is the increased production of the estrogen. Basically the pathology is the estrogen, or we can say the inciting agent is the estrogen. So if there is increased production of estrogen, there is decreased degeneration of estrogen, or there is estrogen intake in the body from outside, that leads to endometrial hyperplasia. The increased function or increased production of estrogen, it can be derived from the ovarian source, from the adrenals, that can lead to all these factors like increased production, decreased degradation due to impaired liver functions, or exogenous estrogen intake. All these factors can lead to relative excess of the estrogen in the body, and this estrogen finally acts on the endometrium, leading to endometrial hyperplasia that can further lead to endometrial carcinoma. Now we have discussed the risk factors. Now coming up to the protective factors. First is multiparity. If the patient has given birth multiple times, so her estrogen has been, we can say the activity has been hampered by the progesterone, or the ovarian quiescence must be there. So the patient has got a protective factor for development of the endometrial hyperplasia. Normal weight, because obesity is a risk factor, then normal weight is a protective factor for development of endometrial hyperplasia. Combined ossiples, since they have got estrogen and the progesterone both, so it has got a protective effect on the endometrium rather than unopposed estrogen, right? Meaning that the estrogen which is not opposed by the progesterone is a risk factor for development of endometrial hyperplasia. Another is progesterone therapy, because the progesterone causes endometrial atrophy and it further decreases the chances of development of endometrial hyperplasia. Menopause less than or equal to 49 years, because delayed menopause is the patient who is having a delayed menopause is likely to have an ovarian activity for a longer time, and so she is more likely to have the risk factor for the development of endometrial hyperplasia. So these are the protecting factors. Now the classification. How do we classify? We classify the endometrial hyperplasia as simple hyperplasia, complex hyperplasia. It can be with atypia, without atypia. Now this classification have been revised, and presently the hyperplasia is only of two types, with atypia and without atypia. This previous classification also gives the development of cancer or progression of these endometrial hyperplasia to the development of cancer in the future. Like simple hyperplasia without atypia the patient has got 1% chance of developing the endometrial carcinoma later. With complex hyperplasia without atypia has got 3% chance. Atypical hyperplasia with atypia has got 8%, without atypia has got 8% chance, and atypical complex hyperplasia, that is complex hyperplasia with atypia, has got 29% chance of developing endometrial cancer. So you can understand that how important it is to detect these hyperplasias. So first we are going to discuss what is simple hyperplasia. Here the endometrium appears thickened to the naked eye. Like if we go inside the endometrial cavity with using a hysteroscope, we see the endometrium is quite hyperplastic, is quite thickened. On histopathology, there are cystically dilated glands without pouching or the invaginations. The glands are there, but they are just dilated, they don't have invaginations inside. Cystic changes is not usually due to blockage of the ducts, but due to extreme hypertrophy, so the cells preserve their columnar shape. Since the underlying cause of the unopposed estrogen is there, so the surrounding myometrium also develops the myohyperplasia and the patient might present with abnormal bleeding. Now coming up to the complex hyperplasia, it's a state of true hyperplasia characterized by an increase in the number of glands. Here the glands overweigh the stroma. The glands are tightly packed. Glands are closely packed and arranged back to back with reduced stroma. Glands have irregular outlines. There are papillary processes and intraluminar bridges inside the glands, and epithelial pseudostratification is present. While in simple hyperplasia, there is no pseudostratification inside the glands. Now coming up to the atypical hyperplasia, it both simple, and that is the hyperplasia containing the atypia. What is atypia? In atypia, the nucleoli are usually large, they lose the polarity, they are pleomorphic, hyperchromatic nuclei, darkly staining, and with parachromatin clumping, increased nuclear cytoplasmic ratio and prominent nuclei. These are the features of atypia. So, if the endometrial hyperplasia has got atypia, it increases the chances of development of endometrial carcinoma later on. Now, what is the clinical picture? Both forms of hyperplasia, whether can be it with atypia or without atypia, can exist without any complaints, right? It can be an asymptomatic finding also. Patient might be asymptomatic and you might have an incidental finding of endometrial hyperplasia. So whenever the patients come to you, or especially the patients who are in later half of their life, like the perimenopausal age group, and patient complains and you incidentally find a very thickened hyperplastic endometrium, you should always try to biopsy it to rule out any endometrial hyperplasia. Simple hyperplasia, if associated with fluctuating estrogen levels, typically causes prolonged and heavy uterine bleeding with intervening short periods of amenorrhea. This is the presenting feature, how you can diagnose, because the patient is having unproposed estrogen, so she will be having endometrial hyperplasia, and the endometrial will keep on growing, it will thicken, and finally, because there is no progesterone to support this, to make it compact, it sheds off. So the patient presents with prolonged period of amenorrhea followed by heavy bleeding. Now complex hyperplasia is often discovered as a result of curettage for menorrhagia. Because of the faulty ovarian function or the endometrial abnormality itself, infertility can be a symptom in both type of hyperplasias. So how to diagnose it? Hysteroscopy adds in localization of an abnormal endometrium which is seen as hyperplastic and may have abnormal vascular patterns, but the diagnosis of endometrial hyperplasia is finally confirmed by the histopathology. But by doing hysteroscopy, you might not miss the lesions which you usually miss by doing the DNCs. Vaginal ultrasound may reveal thickened endometrium, but the final diagnosis is made on the biopsy and the histopathological examination of the specimen. So what to do next? Whenever the patients come to you and she is complaining, she is falling in the perimenopausal age group and she is presenting with abnormal uterine bleeding. So how to proceed? We should go for a transvaginal ultrasound, or then we can do an office endometrial aspiration biopsy. Accuracy is 99 to 98%. It's an OPD procedure and convenient. What is the lacuna then? It's likely that it is 90 to 98%. So why we should go for an invasive procedure? Because the cells which are let's say which are malignant, they have lost their cohesiveness. So if the patient is having some malignancy, then chances of detecting or chances of missing that malignancy on aspiration biopsy are less. Okay, so if it is less likely to miss a malignancy on office endometrial biopsy, because the cells have got lost the cohesiveness and they shed off easily. But if the patient has got an localized pathology, then there are likely chances that can miss these patients in doing endometrial aspiration biopsy and DNC. For those patients, we should do hysteroscopic guided curettage, and it is the gold standard. Even if the patient, you have done office endometrial biopsy or say the DNC, and the patient is symptomatic and you have not find any abnormality on the found specimen in these two procedures, then what to do next? Then also we have to go for a hysteroscopic guided biopsy to miss any lesion which we have to diagnose any lesion which we have missed in DNC and or the this endometrial aspirate. And how to manage? First is the preventive modalities to maintain ideal body weight. Estrogen use in non-hysterectomized patients should be restricted. The patient who have got hysterectomized, we can use estrogen, but that too in moderate doses. Screening of at risk of the women who should be done at periodic interval. The patients who have got history of malignancy, they should be periodically sampled. They should undergo periodic endometrial sampling to detect their cases earlier. Now, the definitive treatment depends on two factors: what is the age of the patient and what is the histological type of endometrial hyperplasia. Because we have already discussed that different type of endometrial hyperplasia have got different chances of developing the malignancy. So this is the flow chart showing. Suppose we have done an we have found endometrial hyperplasia. So we should know what is the histopathology, whether it has got atypia or not, whether it has got complexity or not, whether it is simple. So suppose if she has got no atypia, and then we discuss the age of the patient. Suppose she is young, so she is in reproductive age group. We can manage the patient according to her presenting symptoms. Like if she is presenting with, these patients usually present with oligomenorrhea, infertility, so we can do these patients. And then in elderly patient we can go for LNG IUS system. If the patient has got with atypia, then in old age we have to go for hysterectomy, because complex hyperplasia with atypia may have got the coexisting malignancy simultaneously also. So we should advise hysterectomy to the patient, and if she is young we can go for high dose progesterone for a period of 3 to 6 months and follow up in repeat biopsy. Okay, this is all for the topic, and if there are any questions we can discuss.